And then just so I know the audience I'm talking to, it sounds like are most people from the Colorado region, or is it kind of a smattering of this whole area? Wyoming, Nebraska, Kansas.
Kind of a smattering of the whole area. We have some Nebraska, some
Perfect.
Kansas, some Wyoming, and kind of all around. It looks like Oregon even popped up in the chat
Nice.
there for you. So um, we're
Well, thank
expanding our
you.
footprint.
I love that. And thank you for sharing where you're from. That's super helpful for me too, just to gauge in case anyone asks questions, what protocols are emerging, and sort of different states' preferences for how we treat neonatal emergencies. That is what I'm talking about today. Um, in the chat, if any of you have recently encountered either a precipitous delivery or a really difficult neonatal emergency, I always love also seeing your perspectives, your experiences. It also will help me tailor this conversation a little bit more because it's a very broad topic, as you would imagine. So if anything in particular has come up that you have questions, how should we have handled this neonate? What should we have done for this really difficult precipitous delivery once we're taking care of two patients when we started with one patient? I will pop back and forth between the chat and the presentation as we go along. But the goal today is to talk very generally about the physiologic changes that happen at birth. I'm going to speed through that because I would rather focus more on the pathophys and talking about the specific emergencies that we do encounter. And then one of the things, and I should have created a poll. I'm this many years into making Zoom presentations, and I'm still learning how to do things. But one of the things I did want to talk about and spoke briefly about in a rural Kansas meeting recently was the idea of epi spritzers, also known as push dose or low dose epi, in the neonatal period and in pediatric emergencies in general. And I'm curious if anyone has low dose epi or push dose epi as an indication or as an opportunity for use in their protocols for pediatric patients. So when we get there, I'll kind of pause and read more about what your experiences are in the comments, but it is something we use almost on a daily basis in the pediatric ER here in Colorado. Before this, I was at Rady Children's in San Diego, and then again in Houston at Texas Children's. And I used it very, very frequently, almost daily there as well. So I think it's hit sort of the academic pediatric hospitals. And now one of my missions is to push it out into especially rural areas because most of the time, unless we're a designated critical care transport, we can't start drips, we can't maintain drips. And in shock, sepsis, hypotension, or post-ROSC care, when you're looking at a longer transport for a kid can be game changer. So we'll talk a lot about that today as one of the highlights under these objectives. And then we'll also get through some of the more common neonatal emergencies that we see in the first 28 days of life. Again, feel free to come off mute, interrupt me at any point. Or Desi, thank you for watching the chat in case any big questions come up. All right, so again, speeding through a little bit of this, but the idea of we have a call, whether we know it's for someone who's actively delivering, not in a hospital, or even shows up to the ED, not in the designated L&D area. Or sometimes we arrive to a house with a complaint of abdominal pain, or I've had many teen patients come in and say, I don't know, my stomach hurts. I didn't know I was pregnant. And then suddenly we're delivering a baby in the ER for a teenager who didn't know she was pregnant. We need to be well versed in what's happening in that process so that we know how to manage the babies if they're not acting normally. And thankfully, most of the time, these babies and their bodies are really smart and they know how to figure out how to breathe, and that's through crying. But the idea being all of their physiology is changing during that delivery process. The beauty of the precipitous delivery is that it's going to be a spontaneous vaginal delivery, which helps to kind of push all that amniotic fluid out of the airways, get that into the bloodstream so that you can open up and start breathing. Big things that happen are increased systemic vascular resistance or closure of that right to left shunt. We have a decrease in pulmonary vascular resistance. So we want our blood flow now to go through the lungs instead of bypassing the lungs like it does in utero. And then we are oxygenating that blood as the blood passes through the lungs instead of passing directly right to left and into the system. Like I already mentioned, we clear the fluid from the airways due to airway pressure changes. Again, a lot of that narrowing through the birth canal helps push out the fluid as well. And then you see a tremendous increase in their metabolic rate, which means that suddenly temperature really matters, sugar and feeds really matter. And you see an increase in the catecholamine levels. So it's kind of that fight or flight response to being born and having to figure out how to live without the mom doing everything for them. The idea of delayed cord, it's like a thing, seashells. Delayed cord clamping is that you are increasing the amount of hemoglobin circulating for those babies, ideally around 30 to 60 seconds and not longer than that, so they don't become too polycythemic. But generally speaking, for all infants, you increase the hemoglobin levels at 4 weeks when you see the traditional drop or nadir in the hemoglobin. That's usually around 7 to 9 in a normal newborn. Suddenly they'll have maintained a more normal hemoglobin and you won't see as much of that dramatic nadir, which just helps overall with their metabolic demands, especially in places that are at higher altitude. It can make a big difference. You see less fluctuation in the heart rate and cardiac output. And interestingly, there was one study that noted increased myelin content in the brain at 12 months, so a neuroprotective factor when we are able to safely perform delayed cord clamping. For premature infants, it's all the same benefits, as well as generally decrease in risk in the NICU stay. So decreased intraventricular hemorrhages, decreased rates of necrotizing enterocolitis, which is essentially that bowel death and sepsis, and decreased length in hospital stay. So across the board, it is helpful, but only when it's a safe setting to do it in, right? Any neonate in distress, needing help with respiration, circulation, it is far more beneficial to quickly clamp, cut the cord, and get that baby to the resuscitation or NRP that they need. So again, this is really only when they're safely able to do that. Already talked a little bit about contraindications really being a situation by situation basis. But obviously maternal hemorrhage, cord avulsion, or abruption, it is not going to be safe for the mother or the fetus to perform delayed cord clamping. NRP, generally speaking, I know you all know this, but ventilation is the key to success here. Everything is going to be about ventilation for NRP. You really look at that first 60-second period to decide, are they needing help just with some positive pressure ventilation? Or is it going to turn into, even with positive pressure ventilation, they're needing more resuscitation, their heart rate's below those 100 or 60 markers when you're looking at the heart rate. And then obviously anything below 60, you're performing CPR. If it's between 60 to 100, you're trying for PPV for that first 60 seconds of life. If it doesn't improve, you're also performing CPR. I'm not going to go through NRP extensively with you all, but just again, ventilation is the big thing. These babies, unless they are a known cardiac patient or you've discovered they're a cardiac, like a cyanotic cardiac disease patient, every other baby's issue is going to be that they're not ventilating well, they're not oxygenating well because they're not ventilating well, and that's leading to a cardiac arrest. So already went over this. How many of you have heard of Mr. SOFA? This is a big part of NRP training if you go through that officially. But it's just this idea that we perform on a daily basis, usually without even thinking about it, but trying to formalize this for babies in particular. If it's not working, you have an apneic, bradycardic baby, you're not sure why you're not seeing chest rise, very simply working on mask repositioning. Maybe you need one person on the mask, one person bagging, suctioning, right? These babies have just been through a mountain of amniotic fluid and other secretions. So you do see a lot of secretions blocking their airway. We suction a lot, just opening the mouth, making sure we're in that nice sniffing position. So not hyperextended and not hypoextended, increasing the pressure a little bit. Again, you are meeting, especially in those premature babies, airways that might not be fully open or developed. And so they might require a higher pressure, but being mindful that the pressure that you want is the pressure where you visibly see chest rise. You do not want to exceed that point where you just start to see chest rise because unfortunately they're also at risk of barotrauma and pneumothoraces. It is something that's a little bit easier to manage if needed. If you end up blowing a pneumo, it's very common to see in the NICU, so never feel guilty, never feel bad if that happens. I feel like half the babies in my NICU rotation ended up with a pneumothorax at one point or another because you are trying to hit that fine line of bagging with enough pressure to open really non-compliant airways, but then also not too much where you end up with that pneumothorax. And then alternative airways, if you're just not able to succeed, the AAP has started to recommend eye gels or those LGAs, whatever fits, whatever you have. There's a lot of size zeros that are now available. It just depends on what's in stock. And so that's just that updated PPV guidance. If you don't feel like you have an adequate seal, if you feel like you're struggling with bagging, always feel free to put in those eye gels. You can see size 1 is for 2 to 5 kilos, which are generally speaking going to be most kind of late preterm and term babies. So thinking kind of 37 weeks and up, that eye gel size 1 will fit. LMA size 1, 5 to 11 pounds. And then there's a new supraglottic airway that we actually just last week started using at Children's in Colorado, where you can actually use this for these less than 4.5 pound babies at size 0. So those are going to be kind of your 25 to 35 week babies. Obviously, bagging those babies and or evaluating other risks are going to be important, but nice to know that we have something available that can help us. Oxygen in the delivery room. So just a quick reminder that at 1 minute of life, the neonatal oxygen concentration is only going to be 60 to 65%. So that's kind of where you're starting. Sometimes you'll see a little bit less, sometimes a little bit more. I always remember it as sort of the 0 to 1, the 5 minute mark, and the 10 minute mark because I can never remember the whole breakdown in a high stress situation. So 60% on average at birth. By 5 minutes, you're really sitting at that 80% mark. By 10 minutes, you should start to be about normal. So as long as by 5 minutes, I see the babies more in that 80 to 85% range, I feel comfortable. I feel like we're doing the best that we should be doing for oxygenating them, which is why for full-term infants, we actually start at room air, essentially. FiO2 of 21% is room air. And that's going to basically just help, again, pop open all that non-compliant airway, get them ventilating, and then they're going to, on their own, be able to improve their oxygenation. For the preemies, again, because you have even less compliance, may or may not have received steroids to help with pulmonary development, you're going to go up to an FiO2 of about 30%. I know we're all aware that too much oxygen can also cause oxidative stress problems, especially with ocular development in those preemie babies. I don't want you to worry as much about that because that's a long-term effect. For the babies that are in distress that need the oxygen, go ahead and just give the oxygen. I don't know what people's experience with access is. And Steve, thanks for giving a shout out for the air queue. I just saw what it looked like in our ER last week, and so I'm really excited to be able to use it too. It's going to make life so much simpler. But yeah, so for access, this can be really tricky. You can see an example of a scalp vein over here on the right. These are pretty commonly placed. Great veins in the scalp, very large, open, not as many valves, easier to access, and more central, so a little bit more blood flow than some of the peripheral extremities, which by nature are going to be acrocyanotic in those first 10 minutes. They're not going to have great blood flow to the kind of hands and especially not the feet. So scalp veins are always a great one to go for. There's not a lot of hair there yet either. Sometimes there is, not always. But if you really are struggling, you need access, you're at the point where you just need to be able to give epi or fluids, go for an IO. Don't be afraid of doing an IO. Most of the time with babies, manual IOs are going to be more successful simply because their bones are so fragile at that stage that a lot of times the drills will just go straight through. And it's a little harder to control. You're not going to feel that traditional pop like we do feel in our kind of toddlers through adults, where you know you're in and you stop. With babies, more often than not, you just end up passing all the way through. So I'm always a proponent for practicing chicken bones, or if you have, the more prestigious IO legs or arms that you can practice on, practice those manual IOs for the times that you do need it for the babies. And we prefer proximal tibia or distal tibia if you're going to do an IO on a baby. It just tends to be the best place, the biggest bone at that point, and the safest place for you to go. And then a quick note as well about hypothermia. We already mentioned a little bit about blood sugar and temperature right after birth are big things. The reason we care so much about temperature for babies is because they have this really awkwardly proportioned skin surface area to body weight ratio compared to us as adults. So they just lose tons of fluid, tons of heat through their skin, and they really have no sub-Q fat, no way to sort of keep that heat inside. So they're at higher risk of hypothermia in environments. We care a lot about that in the winter, especially, but generally, even just a 70, 75-degree day, if you think about that environmental temperature compared to your preferred body temperature, which is going to be more in the 97 to 99 range, that 20-degree difference can cause a fairly large drop in a baby's temperature really quickly. So throwing a hat on as soon as possible, drying and warming, wrapping in a blanket, or if the baby's safe, putting skin to skin as soon as possible are going to be the best things. And then does anyone know for our preemie babies, generally kind of 32 weeks and under, but especially in the 20-week range, what we like to do? Has anyone ever seen a baby in a bag? So for our little babies, we get any kind of clear plastic bag. Someone recently suggested whatever your bag valve mask comes in, those kind of clear bags work really well because they're on most of the rigs, available in most ERs, easy access. You don't have to have a dedicated clear plastic bag necessarily, but the bag, what it does is it traps, you put it to the level of the neck, you never put it over the head, but it traps the heat in and starts to circulate that body heat so that it doesn't keep escaping into the environment. Goal temp 36.5 to 37.5. Under 36.5 at birth is considered too low, and over 37.5 would be a little bit too high. And so it's more of that pattern. But if you see, for instance, a 3-day-old who's 35.9 consistently from a rectal temp, we'd be pretty worried about how cold that baby is, whether it's environmental, sepsis, or other issues. And again, this just goes in. We already talked a little bit about how to prevent hypothermia, warm blankets or skin to skin if they can. And then, yeah, this is an example or a picture of a baby in a clear plastic bag. So you can see never covering the head. We like clear because it allows us to assess the baby. We can see them breathing. We can make sure that, if we've put a line in lower down, we still have access to that and it hasn't fallen out. Nothing else has happened. But really does amazing things to keep that baby warm. And then increasing the temperature if you can in the room, ideally to 74 to 77 degrees. Sometimes our rooms are 80 degrees in the NICU and you are melting, but that means the baby's happy. Okay, so that concludes sort of the rapid conversation about physiologic changes, things we can do to help that physiologic transition. Before I go on to some of the more like neonatal emergency type conversations, do we have any comments, any questions, experiences that anyone wanted to share? All right, we'll write it in the chat if you do, and then we'll keep going. I am not sure if anyone was on the talk that I gave. It was either in March or April. I talked a little bit about blow by oxygen. I'm going to re-emphasize it because for our neonates, sometimes, actually not sometimes, a lot of times we'll see babies come in with blow by oxygen on instead of a full mask. So I just want to re-emphasize a couple of points about blow by oxygen. Should we use it? Um, Feel free to comment in the chat if you have experiences with or against blow by oxygen. But the idea being that ideally, if you have anyone on blow by oxygen, you have at least 10 to 15 liters per minute flowing through that bag, flowing through the simple mask, whatever it may be. And then recognizing that room air is 21% fraction of inspired oxygen. And blow by, essentially, if you're even an inch off the face, you're not achieving a fraction of inspired oxygen above 30%. And more often than not, you're just flowing that room air a little bit more rapidly to their face rather than truly providing oxygen. So the idea being, if you feel like a child needs oxygen, just give them the oxygen. Blow by, as you can see demonstrated here, may seem like it's helping, but the babies tend to decompensate over and over again if you're not truly providing ventilation or oxygenation and they're needing it. So assess if they need it. If they do, give it to them. If they don't even worry about it. I generally am an anti-blow by oxygen person because I just think it's a lot harder to control. Babies, you'll initially think they're getting better, and then you'll be doing something else, paying attention to something else, and suddenly they start decompensating again, because it's just so hard to stay at a perfect distance for something that is just not going to help them. And this is all coming from an actual study that looked at transport from an ER to an OR with different distances, 0 centimeters, which is on the face, 5 centimeters, which is just almost an inch. And then looking at different flow rates, 3, 6, 10 liters per minute. Basically, unless you were on the face at 0 centimeters at 10 liters, you really weren't providing any additional oxygenation. So there was a lot more risk of hypoxemia. That's all I'll say about that. For neonates who need the ventilation or need the oxygenation, just put the mask on their face. All right. Now we're going to talk a little bit more about the outside of precipitous delivery range. So they're born, but maybe this is the first few weeks of life, up to about 6 weeks of life. And here are the babies that maybe families just bring in suddenly to the ER, or you get a call about a baby that a family found from their nap from the morning they went in to wake the baby up, and just doesn't look right. So case example here, and I'll be curious if any of you have had a case like this, whether recently or at all in your career, because I think once you've had this concept of a gray baby, you never forget what they look like. You never forget what the parents or the guardians look like, and or the sounds of like concern and screams that you might hear. And you never forget what your blood pressure and heart rate do, because it is a really scary thing. It doesn't happen that often. I have not seen these cases on a monthly basis. It's more like a couple of times a year. But they just stick with you. And so I try to break this down in a way that makes it more of a protocol and less of a, I don't know how to treat this. Should I think about them as shock? Should I think about them as arrest? Just trying to make this more simple for you all, because when you do see them, it does make you feel like you want to panic and you're doing everything you can to stay calm, calm the family down, and take care of this baby at the same time. So here I wrote, a family shows up on your doorstep. Again, that could be a walk into the ER, a walk into the urgent care, or a call from dispatch. And you have a 3-week baby boy. They say they woke him up from a nap and noticed he was barely breathing. Maybe he was grunting a little bit and he looked very sick. You immediately notice that he's kind of flopped out instead of that normal baby tone like you see in this picture, more of that extremities all in front of them, legs kind of splayed out, long pauses in the breathing. Like you do see the chest rise and you're trying to count, is it a 20-second true apnea, or are we just starting to head towards apnea? And then you see he's this ghostly pale blue gray shade. I tried to ask a couple people how they would describe this gray shade, and the best word everyone used was ghostly, because it isn't necessarily that purple cyanosis, but it's also not pale white. It's kind of a combination of the like blue cyanosis and the white pale. And it's just really an eerie color. And it doesn't matter the skin tone, they all look this weird, eerie pale of gray. So, outside of PALS or ABCs, obviously, what are your first thoughts on the potential diagnoses? You see this baby, what are you all thinking? And I'm not going to start talking again until I see at least one comment in the chat. The O2, beautiful. Yep. So we're, for some reason, not ventilating, not getting oxygen. We've noticed those pauses. That's absolutely appropriate. Any others? We found this baby from a nap. What could have happened? Any specific causes of a baby being extremely sick? Big categories are also fine. SIDS, aspiration. Yes. RSV. Perfect. You guys are spot on. Yeah. So thinking about aspiration, was there almost like that brew event, right? Where they choked, they aspirated, and then they just could not recover. Perfect. Sudden infant death syndrome or sudden unexplained infant death, SUID is the other name for SIDS now, is one of those mysterious diagnoses that haunts us all. And it usually is a baby who presents with an unexplained death or is right at the edge of an arrest. Environmental factors and social factors are big plays in that, but an undiagnosed genetic, metabolic, neurologic disorder can be a contributor. Cardiac disorders can be a contributor. And then RSV, perfect. So any kind of infection, right? But RSV for sure, causing oxygen and ventilation issues. But those are all great answers. And thank you so much for contributing. So we've thought a little bit about sort of unexplained infant death, cardiac, sepsis, aspiration. Are there any things that, besides, like I mentioned, PALS, so giving oxygen, assessing if they need CPR, any things that you would instantly think to give or other tests that you would do right away? Yep, bagging, they're not ventilating appropriately. Perfect. That's always correct. Every one of these babies is going to need, yep, suctioning, airway management, bagging because they're not ventilating appropriately. They're insufficiently breathing. So I love that. Awesome. What about checking blood sugars? Would anyone want to grab their kit and just see what the sugar looked like? So that would be a big one too. Perfect. All right. So the big picture, I think, is the best place to start, right? We're thinking about ventilation, but really, what is like one word that can encompass what's happening? Sometimes people would say peri-arrest, but a lot of times we would say shock, right? This baby is in shock. We don't know why. We don't know if it's a breathing issue, if it's a heart issue, if it's a metabolic issue. It doesn't really matter as much as saying, this is a gray baby. All of their systems are not working appropriately. What is the definition of that? It's shock. Because I think once we have that big one word picture, we're suddenly able to say, I don't need to feel emotional and scared. I can think objectively in a protocol and just start stepping down my pathway. So if we look at this baby, we say, what is happening? It's shock. Then suddenly it just becomes a lot easier to quickly intervene and assess the baby. It also allows you to not have any other information because just looking at this baby, you know the baby's in shock. It doesn't matter what the story was as much as what you're going to do about the shock while you assign or delegate someone else to start to figure out a little bit more of the story to give you information. But again, you don't need to operate with any information to be able to treat shock. So shock being the poor perfusion, right? That color alone tells us we are not perfusing and that you have a multi-system failure. If the baby hasn't already arrested, right, you do have a pulse. We already determined that our respirations are inadequate. You guys appropriately assessed that we need to bag this baby and give oxygen. But it also lets us start to think, okay, if we're in multi-system failure, what else might be failing that I can immediately intervene and address? Um, this is a baby I took care of when I work frequently in global health settings, but in Malawi, who came in and I put this picture in because it's just a great demonstration of sort of that listless, limp baby where maybe you're seeing a little chest rise, but you can tell instantly that this baby is very sick and is probably going to arrest if you do not intervene really quickly. And so just again, thinking about limp, listless babies, not the nice, vigorous crying babies. We love a good crying baby, truthfully, in pediatrics because it tells us a lot about their airway working, their breathing working, their tone, and like maybe there's a neuro issue, but for the most part, they're managing to protect their airway. Crying babies tend to circulate well because they do increase resistance, and so they promote circulation to their internal organs. We like a crying baby. We don't like a limp, non-crying baby. So I mentioned PALS. For babies, there's a nice little breakdown that I'm going to go through. Airway, breathing, circulation. But I'm also going to add D and E at the end of this, which are dextrose and environment. So that just triggers us to remember that sugar and temperature, being warm, or if the baby's too cold, warming them up, make a huge difference. I don't know how that line got on here, but just ignore it. Make a huge difference for babies. So for airway and breathing, oxygen. One of the things you'll remember probably from hard elderly, like geriatric cases, is that when you don't have great circulation in your fingers or your toes, it's really hard to get an adequate pleth and a number for a pulse ox. So sometimes this feels like the ultimate struggle, and if you don't address the fact that you know that this is going to be a challenge, let's move on if we can't get it. I've seen a lot of teams get paralyzed trying to get all the numbers before they move on to intervening or move on to other things. So just remember that a baby that looks like this is poorly perfusing everywhere. You might not get a pulse ox number, but that does not mean this baby doesn't need oxygen and ventilation. So operate on your visual instincts, even if you don't have the objective number to support it. Knowing that suddenly as the baby's color comes back, starts to pink up, you might start to see a true oxygen number and a good pleth. And then you can start to finagle everything based on that number. But just because you don't have a pulse ox number doesn't mean they don't need oxygen and ventilation. One tip, and one of the things our nurses will do in the ER is trying to put the pulse ox on their ear, on their earlobe, because it's a little bit more of a central location. Sometimes we have more success getting a true pulse ox waveform and number from the earlobe. But again, don't spend too much time on this. If you have limited resources, limited staff, do your best for one or two attempts and then move on and readdress it later. And then, like we already said, ventilating, starting at an FiO2 of 80 to 100% if you need to. And then you can wean once you have more numbers, right? But at the beginning of this, they just desperately need oxygen. If you think about our oxygen delivery pathways, if you think about shock, it is that inadequate tissue oxygenation, organ oxygenation that's leading to that acidotic chain of events. And so the more oxygen you can get in them right away, the better they tend to do. I know, again, we're always a little afraid of 100% oxygen, especially for babies. But in these cases, it's not wrong to start at that FiO2 that's pretty high, 80 to 100%. All right, so circulation, I have a rule which is just put an IO in immediately. You see a baby like this, it is going to be really hard to find peripheral access because their peripheral veins are so vasoconstricted and shot. And so it's not wrong to work on a peripheral IV, but I I don't even give people a chance. I just say, we're going to get an IO and we're going to work on a peripheral IV at the same time if we can. But if we don't have the staff to do both at the same time, get the IO first and then work on the peripheral IV after that. Only because you do not want to waste time poking around, and then realize, oh my gosh, 3 to 5 minutes have already gone by. We still don't have access and we desperately need it now because this baby's gone into an arrest. And it's so much harder if you're doing CPR to get a peripheral IV anyway. So if you can prevent the baby from getting to the point of CPR by having an IO able to give fluids, whatever they might need, sugar, dextrose, then you're already in a better spot and you've set yourself up for more success. The other caveat to this is that a lot of times with these babies, because they are so sick and they're so tiny and fragile, you blow a lot of lines, and that's just normal. It's normal to feel like I got the IO, I used it once, and now it's not working anymore. We have to move on to another location, or to have a peripheral IV that maybe you got a blood sugar from and then it blew. And so you can't even give meds through it. So knowing that you're probably going to blow lines, just go straight for the IO. Again, proximal tibia, distal tibia, the first two spots that you're going to try. So usually I try, proximal on the left, proximal on the right, distal on the left, distal on the right. Depending on my success and getting those access points. And again, here, manual probably going to be a little more successful than drill, but for the really big babies, maybe they were 8 to 9 pounds when they were born and now they're 3 weeks old. So they're already 10 to 12 pounds. Usually the drill is going to be just fine too. And then for circulation, again, we've defined it as shock. So going based on your algorithm, more often than not, fluids are going to be on your algorithm. And these babies are going to be profoundly acidotic. Usually if we get a blood gas or we get a bicarb, you're going to see really impressive numbers. If they've been apneic, their PCO2 may be in the 60s to 70s. And then you'll see bicarbs in the 5 to 10, lactates sometimes 10 to 20. So they do need fluids. They need help with their circulation. But we mentioned a little bit that cardiac is on the differential for these early babies who look this profoundly sick. So sometimes these are the babies that I will give that 10 cc per kilo incremental fluid boluses, making sure to assess their perfusion and listen for rails in between the fluid boluses. That being said, it is not wrong to go straight to a 20 cc per kilo bolus for these babies. It's really based on your protocol, what you are written to do for these shock cases, and then how you're assessing that baby. I did just want to throw in a shout out that because cardiac is on the differential, sometimes these are the ones that we're giving a push of 10 per kilo listen, another push of 10 per kilo listen, still giving up to that 20 to 40 to 60 cc per kilo total fluid boluses, but just taking it a little bit more incrementally. And then here's where I wanted to pause. I know I mentioned dextrose and environment, but does anyone have low dose epinephrine, sometimes known as push dose epinephrine or epi spritzers on their protocol for kids? Or even for adults? Are you familiar with it at all? Okay, perfect. So it looks like, oh, yay. You guys are ahead of the curve. I love this. For adults. Okay, awesome. All right, so I won't spend as much time then on this. The last group I talked to had never even heard of epi spritzers, so that's why I broke it down a little bit more. But I do want to put a plug in for putting me in touch with anyone and everyone that I might need to talk to say, we need to get this pushed through for kids, not just adults. So if you're already doing it for kids and adults, great, you're ahead of the curve. If you're just doing it for adults, I would love to talk to pharmacists, medical directors, whomever, to talk about how we use it for kids and the life-saving outcomes that we've seen for kids. And if you're not doing it for either, then you can kind of just listen and see if this would ever fit in with your general protocols. But for these gray babies, it's essentially this alternative. I'm going to skip through this and then we'll come back. Alternative to drips. You don't always have drips available. And so especially in the ED, sometimes it's really cumbersome to get the drips set up from pharmacy, get them plugged in, get all of the boluses. And that can be a long period of time for a baby when they really need help with this profound shock. They're probably hypotensive, even if you can't get a good blood pressure. So, how can we mitigate that in the meantime? If we've maxed out fluids, or if we know that it's a cardiac cause and we're trying to avoid fluids, really the only wonderful available alternative is this idea of the low dose epi, push dose epi. So we know this has been used for decades by anesthesia, and now we're bringing it into favor for children in pre-hospital settings and ER settings, and the ICU frequently uses it. It's more of a temporary measure, but again, temporary being a relative term because I've seen this used over the course of hours. If we don't have access to drips and it's the only thing available for us to use. It's there to help with blood pressure, right? Blood pressure changes, so hypotension. It's there to help in those imminent arrest cases. More often than not, that's going to mean hypotension. But as you know, with kids, sometimes they hold on to that blood pressure and they compensate until they just fall off the cliff. So there are times where I will assess this baby is not perfusing, even if that blood pressure number technically is normal. I know that they are not perfusing well. I see that they are cold. I see that their cap refill is 6 to 8 seconds. I see signs of end organ involvement, right? They're altered, they're floppy, they're not breathing well. So even with a normal blood pressure, I will use it for children when I assess that they're not perfusing well. And then post-ROSC care, so you had to do compressions and CPR and you got the patient back. We love giving low-dose epi to kind of maintain their blood pressure, keep them from going back into an arrest on the way to the ICU or on the way to the hospital. And then again, I already mentioned it's really kind of in that sepsis, shock, ROSC protocol bundle, and we use it all the time in kids now. So briefly, just to go over how we actually make push dose or low dose epi. It's easy to Google, interestingly. It's all over the internet now, but I wanted to formally go through it just so we make sure we're doing it right. You are going to pull out your kind of, whether you have a crash cart, code dose file of epinephrine, that 1 milligram per 10 milliliters. So it's 1 ml of epi 1 to 10 that you're going to draw up in a 10 ml syringe. And then the rest of those 10 mLs are going to be normal saline. So you have 9 mLs of normal saline and 1 milliliter of epi 1 to 10, which is essentially going to give you 10 mics per milliliter. So in those 10 milliliters, you're going to have 100 mics total. And the dose for kids is 1 mic per kilo. So for a 10-kilo kid, you're giving 10 mics. And as you remember from this slide, we have 10 micrograms per milliliter. Therefore, for a 10-kilo kid, you are essentially giving 1 milliliter, right? Because you have 10 micrograms in 1 milliliter, and it's a dose of 1 microgram per kilogram. I will say that this works a lot better in our volume-based dosing that we're moving towards, because when you're trying to think of their kilos and the micrograms per kilo, it does get really confusing in the moment. Yeah. So I have a graph that's a much easier snapshot to kind of think in volume-based dosing. For 3 to 5 kilos, which is kind of the standard weight for a full-term newborn, you are giving then, right, 1 mic per kilo, 3 to 5 mics, which is going to be 0.3 to 0.5 mLs. Now, for these syringes, we've drawn them up in 10 ml aliquots. This is when you really, really properly label these syringes as the low dose epi syringes. But then you take a 1 milliliter syringe and you draw out of that 10 milliliters that you've just mixed so that you have much easier volumes for the tiny babies. Because once you have a 1 ml syringe, it's a lot easier to give a half ml or 0.3 mLs, whatever you're needing. So it's sort of thinking through this, making sure if this does get introduced into your practice, that it's part of your PEDS cheat sheets, whatever binders you might have, and that they have the volume-based dosing, as well as very clear instructions on how to mix this. I didn't want to spend forever going through this because, again, it does have a lot to do with your protocols, what's been approved for peds, and your pharmacy teams. But I at least wanted to bring it up and show you how we mix it. Because once you get used to it, it is fairly simple. It just requires extensive label making. And I use this almost like opioids, where I always have two people fact check and verify before giving, because it is easy to accidentally give a full code dose of epi to some of these babies. Not that it would be wrong or harm them in the long run. They're at their end before they code. But it's just always better to have two people check this. And then let me just read. This is how we do it. Oh, cool. Super easy. Love hearing that it's super easy. Um, as someone who is not a medic or a nurse, I know that for me it's a little more cumbersome, but I find that it's really easy to think through volume-based dosing, drawing these meds up, mixing these meds for all of our medics and nurses. You guys are just so much better at this than any doctor ever will be. Okay, so that's the epi spritzer. That was sort of addressing this idea of circulation. We already mentioned dextrose and warming these kids up. Honestly, if I see a shocky baby like this, I'm just telling people to get a dextrose bolus ready. Whatever formulation you would use for hypoglycemia, I'm asking usually for some sort of D10 because we have peripheral access. But I'm just expecting that they're going to be hypoglycemic. And then the instant differential, we talked through most of these already. I wanted to point two others out. So we talked about infection, sepsis, meningitis, remembering that infection can be viral or bacterial or fungal. Any of the microorganisms can cause sepsis, and they can all cause profound shock. I've seen kids go on ECMO more times than I can count from a simple rhinovirus infection. And for some reason, rhinovirus in these 0 to 4 week olds tends to just destroy their system. They don't have any bacterial growth on their cultures. They don't have meningitis. They just have rhinovirus, and somehow they're like the sickest babies I've ever seen. So remembering that sepsis, meningitis doesn't have to be bacterial. Cardiac, so in the first 6 weeks of life, that's when we see those shunts start to close, those ductal dependent lesions come out. And our biggest one that we often think about is coarctation of the aorta, where we'll see a difference in kind of blood pressure in the upper extremities versus the lower extremities. So thinking about checking femoral pulses really quickly can be a helpful way to evaluate, is this baby suffering from a coarctation of the aorta, and now suddenly they have no lower extremity perfusion. Trauma, unfortunately, is a big one. So a lot of abusive head trauma cases will present like this gray baby picture. I'm sorry. Did you have a question on the chat? Oh, no, you're good. So again, abusive head traumas and or any other polytrauma, shaken baby syndrome can present like this. And then metabolic derangements. Sometimes in that 0 to 2 week period, when we don't have the normal, or we don't have the newborn screen back until 14 days of life, they can present with an unknown or undiagnosed metabolic disorder. But in those like 2 to 6 week olds, males in particular can present this gray baby picture with congenital adrenal hypoplasia. So what's essentially happened is they don't have the ability to develop cortisol response to a simple infection or stressor. And then suddenly it's almost like just in general, an adrenal crisis. They come in and they look gray like this. So when we see that, if we're thinking about our instant differential, our instant diagnoses or tests that we can use for diagnoses, whether it's in the pre-hospital setting or in the ER setting, there's a couple of these that can be done regardless. And those would be the pre and post ductal SATs. So checking the right hand for the oxygen saturation, checking the left hand for the oxygen saturation. Is there a big difference? Then we probably have some sort of funny cardiac duct-dependent lesion that's causing the problem. And the 4 extremity blood pressures, really these can just be, do you feel a femoral pulse? Is there a difference in a blood pressure in the right upper extremity and the right lower extremity? If there is a profound difference, again, that may be something like a coarctation of the aorta. And what's nice is that we can do the pre-post-ductal sats and the four extremity BPs in any setting, and it's a super easy way to diagnose cardiac events. Our exam, right? Do we see a big scalp hematoma? Do we see abnormal bruises or just bruises in general all over the body? Do we see deformities? Those are going to be very helpful signs of abuse. Our blood glucose level is going to help us both with sepsis and with metabolic derangements. And any of our metabolic derangements, it's typically going to be low. And then we have a couple of other tests we'll do if we're in the ER setting, obviously cultures for sepsis. We can do a quick ultrasound of the heart to see how well it's pumping. Understanding that in sepsis, the heart, because it's one of the end organs that's affected, might not be pumping well either. Chest x-ray, do you have a really profoundly large heart compared to the rest of the pulmonary space, in which case maybe you also have a duct-dependent lesion, overcirculation of some sort. And then we check for metabolic derangements, kind of electrolytes, so sodium, potassium, and cortisol levels. I usually say skip the diagnosis, except for maybe the blood glucose level and feeling for femoral pulses, and go straight from your instant differential. So thinking in all gray baby cases, I'm going to think of sepsis, I'm going to think of cardiac, I'm going to think of trauma and metabolic. I'm always going to think of those four things. I know it could be a million other things, but it's usually going to be one of those four categories. And I'm going to go straight to my instant interventions. So dextrose, we talked about as part of our ABCDE. But if we have access to it, whether critical care transport, whether it's in the ED, or whether you have it written into a protocol for adrenal shock, for instance, and you're able to call ahead to your med director and say, hey, this baby, this is what they look like. Could be adrenal shock. It's one of the four big things for a gray baby. Can I give hydrocortisone? Tell me the dose. So trying to get kind of that scope of practice through your medical director to give hydrocortisone in the pre-hospital setting can be really life-changing for these babies too. We use hydrocortisone commonly for fluid refractory shock when we're thinking about starting pressors anyway. Those steroids can help with the cortisol response, so it can be helpful both for sepsis and for metabolic purposes. And then once you get to the ER and the hospital, you've already done a lot of your exam, but repeating exams, bruising develops over time. Sometimes you won't see a bruise initially, and then it'll pop up later in your exams. Prostaglandins are going to help prevent those ducts from closing. So giving prostaglandins without thinking about it, if you see a gray baby, can be a life-saving measure as well. And then generally speaking, even though I mentioned it can be viral, it can be fungal, we start these babies on antibiotics and assume it's sepsis until proven otherwise. So that's a lot. I think everything is tailored to the environment that you all are in and what is written into your protocols. But again, just emphasizing if you see a baby who comes in and looks profoundly shocky and you are thinking, we're going to arrest if we haven't already, just automatically go through your ABCDE, right? So airway, breathing, circulation, get access immediately, give fluids. If you are able, give epi before they arrest. But obviously, if they arrest, you're going to give epi just like you would per PALS. Give dextrose without thinking about it. Keep them warm. And then think about sepsis, cardiac, trauma, and metabolic as your four big causes. Okay. So that is the essence of the gray baby. Again, these are really scary, sick cases. A lot of times the sudden infant death or sudden unexplained infant death come in and look like this as well. And, in the ER setting, we'll get the call that you all in the pre-hospital setting have maybe already done 6 rounds of epi before they get to us. But you found them potentially looking completely lifeless, fixed dilated pupils before you even started your interventions. So there's a whole spectrum of what these babies can present as. But when you catch them on the brink before they arrest, you just have a very short amount of time to intervene before they do fully arrest. And that's where I was trying to break this down and make it as simple as possible to just automatically think about the ABCDEs. And then from an ER standpoint, even when you're calling ahead, letting them know if you have femoral pulses, letting them know if you see any other signs of trauma can help them get ready to activate their team and intervene once they get to the ER. It is almost already 7. I do want to stop there. That was the bulk of what I wanted to talk about, and some of the rest of these slides kind of reiterate that information. What questions can I answer so far? And then, does anyone have any experiences where they've seen a baby look like this? That's the big question. It's always better when you haven't, because it is really jarring and it sticks with you for your entire career once you have. The great news is you all are prepared. You know how to take care of sick patients. You see sick patients all the time. Think of these babies as just another sick patient. Don't overcomplicate it. I know it may seem like I just did that for you, but really what I was trying to do was keep it simple and just say they're shock, treat them like shock. The big 4 things that cause this, infection, cardiac, trauma, metabolic. There's some simple interventions that we can do without any diagnoses, and then leave it to the teams to kind of filter through and figure out what the actual cause is later. Awesome. I am going to breeze through a couple of other things, but I think we'll end early tonight if that's okay with you guys. But do want to mention 2 or 3 other things before we finish. So respiratory emergencies, in general, I did want to mention respiratory distress syndrome. This is something that you'll see more specifically in those premature babies, so kind of 34 weeks and under. Maybe they got sent home from the nursery at day of life 2 and they're coming back, or you're getting a call about them day of life 3 to 7. Usually what's happening is they may still have a lot of fluid in their lung, especially if they were born by a C-section and discharged a little early, seem to be doing fine. A lot of these babies just develop issues with breathing. And more often than not, it is a surfactant deficiency. The best way to treat them is helping them ventilate, whether that's bagging, whether that's giving them some sort of like bubble CPAP, positive pressure, just to help them breathe a little bit better, or just giving them oxygen until you can get them on a positive pressure device can be really helpful. Again, usually it's going to be shortly after birth, although I've seen it up to about 5 to 7 days of life. So it's very possible that a baby's gone home and then is needing to come back with this. A lot of times you're going to see desaturations as one of the first signs, but you'll start to see retractions, grunting. They almost look like a bronchiolitic, but in that very early newborn period. Let me see, this is a video. If it's going to work. For some reason on Zoom, the videos don't like to work, so I apologize. I did mention the pneumothoraces. Again, sometimes this is just the baby is born with it. Sometimes it can be barotrauma. No fault of anyone's. Never feel guilty, like I already said. But remembering that it is more common if they're requiring any kind of positive pressure ventilation. Just like any pneumothorax, you might see a sudden deterioration. You see chest rise, but you're not able to get the oxygen saturation over 90%. There's a cool, you basically take a flashlight, turn the lights off, and you can transilluminate their lungs, and you can actually see where the pneumothorax is. And because babies have such thin skin, it works really well. So if you're ever unsure, just grabbing any flashlight, and then you shine it on one side of their lung, the other side of their lung, and you can tell if there's a big pneumothorax there. It also is basically like doing an ultrasound, but just with a flashlight. If you need to needle decompress them for any reason, it shows you right where the pneumothorax is. You go in the second intercostal space, which is our recommendation for babies, on either side that's affected, and then suddenly you've fixed the problem. Super simple. So this is trying to show, I don't know that the video is going to work again, but trying to show how you can transilluminate. This is just a regular flashlight that someone was carrying in their pocket. Sorry, that's not working. I'm going to skip past brew. This is again something, it's like a benign usually ends up being a benign event, although a scary event for the family, but typically only lasts a couple of seconds. These are not the great babies. Neuro emergencies, briefly mentioning seizures. Neonatal seizures are tricky because sometimes you don't see the generalized tonic-clonic seizures. You might just see rapid eye blinking, lip smacking. They might be just in a really stiff, more of that clonic phase. And then usually you'll see cyanosis, hypoxemia, and potentially apneas as well. Occasionally, we start to think about infantile spasms, but those, because they last for such a brief period, usually just a few seconds, don't cause as many issues with breathing. Treat seizures just like you would always treat seizures. Don't be afraid to stop a seizure in a baby, especially if it's causing them to have apneas and insufficient ventilation. Obviously, you can bag them, but stopping the seizure is going to be equally helpful. Checking glucose. Hypoglycemia can be very profound in babies, like we've already been talking about. And so remembering that checking a glucose and giving glucose might be the one thing that's going to stop their seizures. I've also seen a lot of sodium deficits. Parents who don't realize in a hot summer day that giving free water is going to cause a very rapid drop in a sodium level. So as we head to summer, thinking about that. And then knowing that the sodium level, until it's corrected, and usually we're giving like hypertonic if it's a baby that's like a sodium less than 120 and they're seizing. Obviously, over 120 seizures are stopping on their own. We're trying not to over correct because of other problems, but sodium can be a pretty profound one for these babies. And it's usually something like free water if they don't have any other medical history. And then cardiac emergencies. So just being aware of a lot of our cyanotic heart diseases, our duct-dependent lesions, that pre-postductal sats, and then four extremity blood pressures can be really helpful for diagnosis. Um, just doing an exam, asking questions to the family. Do they have a lot of issues feeding? Are they sweating a lot when they feed? Have they been failure to thrive or not gaining weight appropriately? Can all be clues to that exam. And then if you hear a murmur, obviously that's a big red flag for some sort of cardiac event. Treating, again, just supporting airway, breathing, circulation. In the hospital setting, eventually they'll get an echo. And then for those gray babies who present really early, looking profoundly ill, prostaglandins will help keep those ducts open until the surgeons and the cardiologists are able to come in and make a more appropriate diagnosis and treatment plan. GI emergencies. So babies, obviously, we think about all of the abnormal anatomical and structural variants. Volvulus with malrotation with volvulus is one of the ones that presents early on, almost like necrotizing enterocolitis does in the NICU, where they have bilious vomiting. So if you see a baby with bilious vomiting, I think all of us would think there's a GI issue here. And usually the most common thing is going to be malro with volvulus. The big thing for you all to know is that don't keep feeding them, but they need dextrose. They haven't been absorbing any nutrition. They're probably not only septic, but hypoglycemic again. So outside of decompression, getting access, getting fluids, and getting dextrose in is going to be what helps this baby. If you're seeing a bilious baby or jaundiced, but bilious emesis, that's going to be the easiest and the quickest way to help treat them. And then a couple congenital defects. I don't know how often we see this nowadays in the pre-hospital setting outside of families or mothers who didn't have a lot of access to or didn't use their prenatal care a lot. So more often than not, these are going to be diagnosed before the baby's born, and then there'll be expectant deliveries with a whole surgical and nursery team available. But in the mothers who have precipitous deliveries, didn't have any prenatal care, and you do see one of these abdominal wall defects, the best thing again is to place the whole baby kind of in that clear sterile bag again, because what that does is it prevents heat loss, prevents fluid loss, and it keeps that area nice and moist. So you're trying to prevent any kind of basically necrosis of the bowel. And then the last thing I'll talk about diaphragmatic hernias. Again, some of these are really odd and you don't see them except for maybe one or two times in your career because a lot of times they end up born in the hospital. They go straight with surgery to correct the issue. And we never see it in the kind of ER or pre-hospital side of things. But occasionally you might have a baby where you're like, I don't hear any breath sounds on the left side. And I actually feel like I hear gurgling. So those are the ones that are kind of funny, and you'll end up in the hospital setting getting a chest x-ray and seeing essentially an intestinal pattern where the lung should be. And then the diaphragm is either fully missing or you cannot see it and visualize it because it's not intact. There's a big defect in it. And that's where you'll start to see bowel contents in the pulmonary area. A lot of times you may see tracheal deviation. One of the easy diagnostic tricks for this is if you're bagging a baby because they're not breathing well because half of their lung is not working, all of a sudden they're going to decompensate with the bagging. And that's because you're filling their stomach up with air. And then their stomach is going to, as it fills up with air, start to push all of those mediastinal structures over. Typically, it's going to be pushing them from the left to the right, and then the right lung suddenly is compromised, is unable to ventilate, and it's almost as if they're developing a tension pneumothorax, but in this case, that's not what it is. It's the stomach is full of air, and they need rapid decompression of that stomach. So throwing an OG or an NG in is going to be really helpful. Get that air out. You allow those structures to go back to midline, and then you realize very quickly there's not a lot else we can do until this is surgically fixed, except for try to maintain an equilibrium for these babies. So these ones are really tricky, but they get worse with bagging, not better. And that can be an easy way, especially if you see a tracheal deviation with bagging, to diagnose a diaphragmatic hernia. All right, so to summarize some of our key points here, ventilation is the most important intervention for the apneic or bradycardic neonate, thinking about NRP and Mr. SOPA. Hypothermia will increase the morbidity and mortality in neonates. Keep them warm, put the preemies in a clear plastic bag up to their neck. If you master the normal newborn exam and get used to checking babies out kind of head to toe whenever you happen to see a baby, especially if it's a well baby, that will help you diagnose the things that are wrong when you do see them. So it just helps with pattern recognition. I know what a normal baby looks like. So if I'm seeing a baby and there's something off, it's a lot easier to identify what it is. Yes, A, B, C, D, E, no blow by. And then thinking about our gray baby, prostaglandins, hydrocortisone, fluids, and epi are going to be the biggest life-saving things outside of our A, B, C, D, Es. So that was a lot of information in a short period of time. I am happy to answer any other questions you might have, or if you're just sick of hearing me talk and ready to get on with your evening,
You what?
totally understand.
Give me just a second and I'll get the QR code up.
Thank you.